Welcome to Patient Education and the role of the clinician in providing not only optimum care, but in assuring that the patient is involved in the process of disease management. The ultimate goal of patient education is to increase competence and confidence to allow the patient to self-manage their condition. Although this book was technically written for nurses, its application for all medical personnel is evident, and patient education is as important for respiratory therapists as it is for nurses, physicians, and other healthcare professionals. Nursing has a long history of education beginning in the mid-1800s with nurses like Florence Nightingale and her development of the first nursing school. Teaching at the time focused on adequate nutrition, fresh air, exercise, and personal hygiene. Respiratory therapy, a relatively new profession with its roots beginning in 1946, with a meeting of Dr. Levine's students and other interested doctors, nurses, and oxygen orderlies at the University of Chicago Hospital, formed the Inhalation Therapy Association. Not until 1950 were the standards of effective administration of inhalation therapy established, setting the stage for formal education in the field. In 1966, the more formal Education Forum became a venue for managers and educators to meet and develop standards of care, including patient education. In 1975, the American Hospital Association, AHA, distributed a document titled A Patient's Bill of Rights, which was revised in 1992 and must be posted in every healthcare facility across the U.S. Patient education was a significant part of this Bill of Rights. The Joint Commission also mandates patient education be provided and documented to improve patient outcomes. In the 1980s, education took a paradigm shift with focus from disease-oriented to more prevention-oriented approaches. In 2000, and again in 2010 and 2020, the federal government published Healthy People, which is a document that set the national health goals and objectives for the next decade and looked to cut cost of healthcare and prevent the premature onset of disease and disability by focusing on improved lifestyle-related and preventable causes of disease through educational intervention. Various social, economic, and political forces have affected clinicians' roles in teaching and include the growth of managed care, increased attention to health and well-being, cost containment, and concern for continuing education of clinicians to prevent malpractice and incompetence. Other trends include consumer-driven demand for more knowledge and self-care, an aging population, an increased prevalence of chronic conditions, advanced technology increasing the complexity of care and treatment in home and community-based settings, more rapid discharges and procedures performed in an outpatient setting, improved outcomes due to patient health literacy and compliance, and advances in genetics and genomics leading to greater need for education and decision-making. The purpose of patient education, as stated before, is to increase competence and confidence in the client's ability to self-manage and for staff and students to deliver high-quality care. Benefits of education include increased consumer satisfaction, improved quality of life, continuity of care when patients are discharged, decreased patient anxiety and disease complications, better compliance to treatment, and increased independence and ability to self-care for the patient. Benefits of education to the staff include increased job satisfaction, better clinical relationships, increased autonomy, and opportunity to affect change. Education process is defined as the systematic, sequential, planned course of action on the part of both teacher and learner to achieve outcomes of teaching and learning. Teaching, instruction, is defined as a deliberate intervention that involves sharing information and experiences to meet the intended learner outcomes. Learning is defined as the change in behavior, knowledge, attitudes, and/or skills that can be observed or measured and that can occur at any time or place as a result of exposure to environmental stimuli. Patient education is the process of helping clients learn health-related behaviors to achieve the goal of optimal health or independence and self-care. And lastly, staff education is the process of helping clinicians acquire knowledge, attitudes, and skills to improve the delivery of quality care to the consumer. The Assure model is useful to help clinicians organize and carry out the education process and include A. Analyzing the learner, S. Stating the objectives, S. Selecting instructional methods and materials, U, using instructional methods and materials, R, requiring learner performance, and E, evaluating revising teaching plans. Barriers to teaching are anything that impedes the clinician's ability to optimally deliver educational services and include lack of time, inadequate preparation of clinicians to assume the educator role, personal characteristics such as motivation to teach and skill in teaching, and until recently, low priority given to teaching. The Joint Commission, TJC, has made strides in this area. Other barriers are environments not conducive to teaching learning, such as lack of space, privacy, frequent interferences, etc., absence of third-party reimbursement for patient education, there is no separate billing code, doubt that education changes outcomes by some clinicians, and inadequate documentation systems to allow for ease of recording teaching efforts. Obstacles to learning are factors that negatively impact on the learner's ability to attend to and process information, and include limited time due to rapid discharge from care, stress and anxiety when dealing with an acute or chronic illness, sensory deficits, and low health literacy or low literacy in general. Other barriers to learning include loss of control, lack of privacy, and social isolation in the hospital environment, and readiness and motivation to learn, learning styles, and extent of behavioral changes required, particularly if these changes are multi-stepped and complex. Lastly, lack of support and positive reinforcement from clinicians and significant others can decrease motivation, and other psychological obstacles such as resentment of authority may impede learning. The complexity and dehumanization of the healthcare system itself can be a huge barrier to learning. Some helpful questions that may assist in teaching and learning may include: how can the healthcare team work together to coordinate educational efforts? What are the ethical, legal, and economic issues involved? What are the theories, methods, and tools to determine learning need, readiness, and styles? Which learner attributes aid or decrease learning? What can be done about inequities in the delivery of healthcare education? How do we develop and implement an effective teaching plan? And how do we tailor teaching to meet individualized needs? And lastly, what are the common mistakes in teaching, and how can we evaluate teaching and learning? These and other questions will be answered in the lectures throughout this course.